So thank you, Ben, for that very kind introduction. And thank you, all of you for giving me this opportunity. I'm going to talk very big picture, and then I'm going to talk subcellular level. And I hope it doesn't completely overwhelm you because I've only got 20 minutes to do it. I want to start with some of what we've already heard. We have a mental health crisis on the planet. Mental disorders prior to the pandemic affected about 1 billion people. That represents about 13% of the world's population. And that is just annual prevalence. If you look at lifetime prevalence, the United States, about 50%. Some reports from Australia, 80%. But rates are even higher now due to the pandemic. Mental disorders are at least one of the leading causes of disease burden and disability worldwide, and the World Health Organization, depending on what statistics you're looking at and whether people are getting checks for their disability, the World Health Organization says actually depression is the leading contributor to disability worldwide. And there's this curious thing. Rates of mental illness across a wide range of diagnostic categories have been increasing for decades, even before the pandemic. Rates of autism, we heard. The last 20 years, look at CDC data, quadruple the rate in 20 years. ADHD, in case you haven't heard, we've got an Adderall shortage. Bipolar disorder, 20 years. Rates in adults have doubled. Rates in children and adolescents are through the roof exponentially. And rates of just simple, plain old bread and butter depression. Gallup polled us an annual survey in 2023. Both current prevalence and lifetime prevalence reached an all-time ever recorded high. What are we doing about this crisis? Well, the reality is we do have treatments and they do work for people. We've got a wide range of medications, psychotherapies, hospitalizations, group therapies, ECT, TMS, ketamine, psychedelics, addiction recovery programs. There is no doubt these treatments save millions of lives every year. Unfortunately, they just don't work for everyone. Treatment resistance affects anywhere from 20 to 60% of all patients who receive psychiatric treatment, depending on what study and what population they look at. This shouldn't be news, but our psychiatric treatments do not cure mental illness. They are not disease-modifying therapies. At best, we're lucky if they reduce symptoms. Why can't we do better? In the end, I would argue it's because most leading scientists, psychiatrists, if you ask them a simple question, what exactly causes mental illness? They'll say, oh, it's just too complicated. So many factors, nobody knows. All we know are risk factors. And we put them into the biopsychosocial model, and we've heard about these today. There are neurotransmitters, genetics, inflammation, hormones, but psychological and social factors, ACEs, trauma, loneliness, all of these things play a role. But how exactly do they fit together to cause mental illness? This is the question of the century. If we are ever going to make progress in the mental health field, we have to answer this question. How do these things fit together? And what I am here to propose is that research over the last 20 years, cutting-edge research, not really well known in the mental health and neuroscience fields, cutting-edge research from numerous disciplines allows us to once and for all answer this question. Mental disorders, I am arguing, are metabolic disorders affecting the brain. What does that mean? All of the risk factors impact metabolism. Metabolic dysfunction in cells can, in fact, explain why the brain would malfunction. This is a way to integrate those biopsychosocial risk factors. And once and for all, it's a way to integrate what we call mental health and physical health. But that leads to another common sense, simple question. What exactly is mental illness? If you're going to tell me what causes it, you have to tell me what it is first. And as many of you probably know, we have a conundrum in the mental health field. We have this thing called DSM-5, and we have all these nice labels: autism, schizophrenia, alcoholism, bipolar disorder, anorexia. And those are all different disorders. And so they must have different causes, right? And they certainly have different treatments. But there are three problems with DSM: heterogeneity, comorbidity, and quite frankly, a lack of validity. So heterogeneity says that two people with the same label can have wildly different symptoms. We heard about autism. Some people have cognitive impairment, seizures, and are living in group homes, unable to care for themselves. And then we see billionaire businessmen in the news every day who also share this same diagnostic label. Does anybody in their right mind really believe that those two people have the same brain condition? There's comorbidity. Nationwide, if you have one mental disorder, 50% chance you have more than one. If you get treatment for a mental disorder, on average, you have 3.5 diagnostic labels. And a lack of validity. Tom Insel and many others have said these are not, although these are household words, and we think we know what we're talking about, they are not valid disease constructs. So the NIMH proposed a different model, the research domain criteria. There are competing models, high top. These tend to be trans-diagnostic models, saying that mental illness, we need to look for a broader trans-diagnostic cause. And so if I stop right there, the mental health field is a mess. We have all of these different symptoms and labels and heterogeneity and comorbidity and a lack of validity. And what on earth are we ever going to do? But there are many lines of research now that have been percolating for the last couple of decades that suggest something both shocking and immensely helpful. Mental disorders, all of them, every label in DSM-5 appears to share some common pathway. This was first proposed in 2012 by Leahy, who described a general factor for all internalizing and externalizing mental disorders. This was expanded upon in 2018 by Caspi and Moffitt to look at all of the labels in DSM. And they called it a P factor, that if you look at genetic risks, there is no schizophrenia gene. The gene that increases your risk for schizophrenia also increases your risk for autism and bipolar and seizures and lots of other brain conditions. And in 2023, just this year, Brandt et al. Suggested, oh wait, it's not just the mental disorders. There are all of these physical disorders that also appear to share this common pathway. And they called it a D factor. What I'm arguing is that metabolism, and I'll get a little more specific about what that means, is the only way to connect the dots of what I have just reviewed. But I want to take another step back because we have to answer a simple question. Well, what is mental illness? What is it? And I am arguing that mental symptoms are just like pain. That there are normal, DSM-5 describes for us things that are normal, extreme, and disorders. So pain is a normal sensation that everybody experiences. It is not a disorder. You might want some treatment for it, you might need some help for it, but it is not a disorder of your body. You can have extreme pain if you get surgery. It can be extreme and prolonged, but that too is not a disorder of your pain system. And yet you can have a pain disorder in which your pain system is misfiring and causing the sensation of pain when you should not have pain. We need to distinguish these things. What I'm arguing is that every mental symptom falls in a similar continuum. Anxiety is normal. All of us have it. It can be extreme if you're being relentlessly bullied and teased on the playground. And it can be a disorder when you have a panic attack for no reason out of the blue. Now, if we're really going to come up with a unifying theory for what causes mental disorders, what would we actually need to account for? And this is a model that I have put together. We'll see if it stands the test of time. But what I would argue is if you look at all of the neuroscience data, we need to explain why some brain regions would be overactive or hyperexcitable. At the same time, simultaneously, we would have to be able to explain why other brain regions might be underactive. We need to account for neurodevelopmental and neurodegenerative disorders, and we need to account for maintenance problems in cells, the accumulation of abnormal proteins like amyloid or tau proteins or myelin defects, maintenance problems. So can any one thing, can a P factor really account for all of this? And what I'm arguing is, yes, it can. Metabolism. This is nothing new. This is about integrating over a century of clinical and epidemiological data and almost a century of basic science research. So in the 1800s, researchers knew about the connections between type 2 diabetes and insanity. Basic science research dates to the 1930s. This applies to all of the mental disorders: depression, anxiety, PTSD, schizophrenia, bipolar, anorexia, alcoholism. What do I mean when I say metabolic problem? I mean that when we look at brain scans or when we measure blood biomarkers, when we do these things, we see differences in the levels of lactate, glucose metabolism, the ATP to ADP ratio, reactive oxygen species, redox markers, inflammation, cortisol. All of these things, it gets very complicated very quickly, but all of these things are metabolism. We've heard about inflammation. We heard about the functional assessment. All of those things tie directly to metabolic function. What is metabolism? A lot of people think it's burning calories. It's a lot more than that. It is, a simple definition might be the process that all living organisms use to convert food into energy or building blocks, used to maintain or grow cells, and also managing waste products. It is fundamental to the definition of living organisms. And in this respect, most people will say, well, then, Chris Palmer, that's nothing helpful. Metabolism, you're saying it's metabolic. Well, if metabolism is everything, then of course mental illness somehow or another has to be related to metabolism. Big deal. How does that help us? If you ask another common sense question, well, what exactly controls or regulates metabolism? The real answer is numerous biopsychosocial factors. It's really complicated. There is no one thing. But I can tell you, if you really zero in and do your research on cutting-edge research over the last 20 years, you will always be led to these tiny things in our cells called mitochondria. Now, most of you know mitochondria as the powerhouse of the cell, but the cutting-edge new phenomenon is that they are so much more than that. They are critical players in regulating the function, structure of cells, and just metabolic health in general. And if you do a deep dive into the science of mitochondria, you will see that they are a very plausible way to get to a P factor. That they control the production and regulation of key neurotransmitters like serotonin, dopamine, norepinephrine. They are involved in the epigenetic control of DNA, turning inflammation both on and off. The gut microbiome affects them, diet and exercise affect them. But ACEs, stress, trauma, impact their function and metabolic health. Drugs and alcohol do, sleep, hormones, all of these things Mitochondria are playing a role in many of these things, and these things are impacting mitochondria. And if you look at what are the consequences, what if mitochondria in cells aren't functioning properly, what might happen, you can easily get to the buckets that we need to be able to account for. Hyperexcitability, underactive function of cells, both neurodevelopmental and neurodegenerative disorders, and maintenance problems in cells. And so what does this do? This theory, there is no doubt, there are leading psychiatrists and neuroscientists hot on this trail. Biotech companies are hot on this trail. And this, I believe, will lead to a new day in the mental health field. But what I'm much more excited about is what can we do now, today, for real people based on this information? First and foremost, we need to integrate human health care. We have to stop separating mental and physical health. We have to stop prescribing pills that cause obesity and diabetes and cardiovascular disease and pretend that it's not our problem. We are not serving our patients well. That is not optimal human health care. We need to do better. There are many treatment options, including current treatments that we're using. A new theory doesn't replace what we're doing, but it can actually help explain what we're doing. We need to rethink our current treatments. We have all of these agents that affect serotonin. And many psychiatrists think, well, it's a serotonin imbalance in the brain, right? Well, actually, serotonin, 90 to 95% of serotonin in the human body is produced in the digestive tract. Serotonin plays a powerful and immediate role in both mitochondrial function and metabolism and metabolic health. We need to think about what are our treatments actually doing, and when we understand what they're doing, we might be able to create more sophisticated treatment strategies. You've heard a little bit about the ketogenic diet. I'm not going to belabor this, but there are many patients now who have achieved long-standing, durable remission for more than 15 years off of psychotropic medications, who had debilitating chronic schizophrenia, schizoaffective disorder, bipolar disorder. These treatments can save lives. I am proud to announce that we are starting the Metabolic and Mental Health program at McLean Hospital and Harvard Medical School. A global research effort is underway here at Stanford, also Harvard, Oxford, Hopkins, and numerous other prestigious universities. Biotech is hot in pursuit. If you do not know this, you're behind the curve. These biotech companies have been pursuing this for years, and some of them more than a decade. And with that, I thank you.
Hi, thank you. So I practiced in pain management for many years and couldn't echo more the, mental health, pain management, all physical and mental as a combination of a continuum. So in terms of how do we approach it without labeling people one or the other, one of the thoughts I've always had is everyone's autonomically dysregulated, right? And we have simple tools now like HRV and wearables that we could use. And I thought if we had a primary diagnosis in the nomenclature of autonomic dysregulation syndrome as a basic parallel diagnosis to all of the diagnoses we have. So when someone comes in with headaches and irritable bowel syndrome and fatigue and stress, they're all going to be autonomically dysregulated. And then if the diagnosis is there in the nomenclature, we could at least offer them things in the world of stress management. So I was wondering your thoughts as a first-line step of that.
So we could definitely do that, but some people with mental illness don't have objective biomarker signs of autonomic dysregulation. And so we would leave a lot of people out. So I would actually prefer the term neurometabolic dysfunction or neurometabolic disorder. But again, this is about integrating mental health and physical health. A lot of people get lost with, so Chris Palmer, you're saying that it's like everybody's got insulin resistance or autonomic dysfunction, and then that leads to a serious mental illness. No, not necessarily. What I'm saying is that ACEs increase risk for every mental disorder, every single one. ACEs increase risk for every metabolic disorder too. We need to stop ignoring that. We need to put our brains around the complex science of how exactly does that work. Is inflammation involved? Yes, absolutely, but it's more than inflammation. Are hormones involved? Glucocorticoids? Yes, they are, but it's more than that. And that information, we've known that inflammation is involved. We've known that glucocorticoids are involved since the 1980s. It hasn't done anything useful. If we wrap our brains around the complexity of the science, we do know enough to develop new treatment strategies today. And I believe we can help people today. But yeah, I mean, at some point, we're going to have to come up with a new diagnostic nomenclature. We're going to have to stop separating mental and physical or brain and physical health. The brain is, in fact, an organ. And it can be affected just like the heart and the pancreas and the liver. Like, metabolic dysfunction impacts the whole body, including the brain.
My name is Alexei. I lead the company Romi Science. We do unbiased metabolomics and study a lot of the complex biological systems. So my question is, so we're looking at metabolites and metabolomics. As you rightfully suggested, microbiome plays an important role producing metabolites. And upwards of 90% of metabolites that they produce, we just don't know what they are. So not to mention that we have to measure metabolism, but majority of them we just don't know what they are. There's so much unknowns in there, and then like to understand all this requires a lot of work, a lot of simple kind of testing, and I would argue you versus you approach, essential like longitudinal analysis and testing, which would require simplification in terms of how we collect the data, how we analyze the data. So I think I'm more of like a comment that I wanted to make on your talk, but it's fascinating. Thank you so much.
So the one thing that I would say is you're right. There is so much about metabolism and metabolomics and mitochondrial function that we don't know. The good news is that these rates are skyrocketing over the last 4 decades. The rates of all of the mental disorders are skyrocketing. At the same time that rates of obesity and diabetes are skyrocketing. We don't need to know the details of that science to know what environmental patterns can contribute to obesity and diabetes. And what I'm arguing is mental illness. We can go to simpler lifestyle strategies or extraordinarily complicated, as we heard in the prior study, extraordinarily complicated functional metabolic workup. But either approach can work for a lot of people. And what I'm finding time and again in countless people now, thousands of people, is that they clean up their diet, they prioritize their sleep, they get off of substances that are harmful to metabolism, which includes marijuana, smoking, vaping, alcohol. You dramatically reduce your use of those substances, and they get better without psychotropic meds. And now most of you hear that and you're like, well, yeah, kind of, we already knew that. And yet we're kind of already not doing that. We're kind of sort of just prescribing pills right and left. And we have a mental health crisis. And maybe mental health clinicians need to start saying, let's clean up your diet. Let's prioritize your sleep. Before you get a pill, you've got to do these 5 basic interventions. And my guess, based on the thousands of people that I'm hearing from, my guess is we'll probably actually get a really good percentage of them better before they go down this horrible metabolic path. Will there still be really complex cases? Yes, there will. Are there many unknowns? Of course there are. But if we start doing the research, investing in companies like yours that are doing metabolomics, then I think we can make better progress. But with that, I thank you.
Thank you so much. Yeah.